We're going to be talking basically about atlanto-occipital dislocations. Now, there is unique anatomy at the craniocervical junction. The load comes down through the occipital condyles into the C1 lateral masses, and then is transferred into the C2 lateral masses, and then becomes ventral into the vertebral bodies in the subaxial spine. So we need to remember this load sharing as we're getting fixation for these patients. 15% to 20% of AODs can be associated with subaxial fractures, an important point to remember. And these injuries can result in either devastating neurologic injuries or actually no spinal cord injuries and be very subtle. Those are the ones that I think are the most dangerous because those are the ones that have been missed historically. Now, at the craniocervical junction, it's all about the ligaments. We have the occipital-atlantal ligaments, capsular ligaments, the atlantoaxial capsular ligaments, the alar ligaments, the transverse ligaments, and the tectorial membrane. And we have to try to evaluate all of these through MRI when we're trying to determine and define an atlanto-occipital dislocation. Interestingly, we did a finite element model, analysis looking at just disruption of the atlanto-occipital capsular ligaments and found that when we disrupted these ligaments, there was actually more motion at C0, C1 than if we disrupted the transverse ligament, the tectorial membrane, or the alar ligaments. So that actually the capsular ligaments are really what we worry about the most. Now, again, these are often thought of as devastating injuries, but remember, you can have fairly innocuous injuries, and these can result in great consequences if missed. The incidence in patients dying of craniospinal trauma has been estimated at up to 25%. There's a high incidence in the pediatric population, probably because of bigger head size relative to the spine. It's thought to be involved in high-speed motor vehicle accidents or auto versus pedestrian accidents. And the improvements in trauma care, again, are yielding a number of survivors, something that we saw a number of times over the years and Jens has published on from Harborview. Now, the typical classification was initially presented by Dr. Trinellis, and it was simply based on where head position, I think, was at the time that the x-rays were taken. You could have anterior displacements, axial displacements, or posterior displacements. But again, remember that these are such unstable injuries, it just depends on where the head is relative to the position of the spine. And this is not a classification system that I think is particularly useful in determining how to treat these patients. What is more important is to determine if the patient does have an atlanto-occipital dislocation. And this work, looking at the condylar C1 interval in children with atlanto-occipital dislocations, was first published by Dr. Pang. And what they found is that in normal patients, the CCI was only 1.2 millimeters, but in atlanto-occipital dislocations, it was anywhere from 5 to 34 millimeters. So certainly in children, if you have more than 4 millimeters of displacement of the condyle on C1, you have an AOD. But this number has actually been looked at in adults and found to be even shorter. So the CCI is shorter in adults with cutoff values of 1.5 in normal individuals. And as you can see here, when you look at a cutoff interval of 1.5 millimeters, the sensitivity of diagnosing a atlanto-occipital dislocation is 100%. Now, radiographic workup with the ubiquitous nature of multi-detector CTs now really is dependent on CT. You can look at the Bayesian dental interval, which should be less than 10 millimeters. Again, you can look at the occipital atlantal joints, which should be less than 1.5 millimeters in adults, and also the atlantoaxial joint, which should be, again, around less than 1.5 millimeters in adults. MRI is also performed, and if you see fluid in the AO joints or the atlantoaxial joints, this is very indicative of an atlanto-occipital dislocation, as is disruption of the tectorial membrane. Now let's look at some series from craniocervical dislocation survivors. This is a series we were all involved with from Harborview, and it had 17 adult survivors of craniocervical dislocation. Most of them were involved in high-speed motor vehicle crashes or high-speed pedestrian motor vehicle accidents. And what we found was that there was often a delay in diagnosis of 76% of the patients that we saw had a delay in diagnosis. Now, this was in the era when we just used x-rays as part of the trauma evaluation. Obviously, with multi-detector, multiplanar CTs now, this should be much, much lower number. But the initial diagnosis was made only in 25% of patients. There were obviously a lot of associated closed head injuries and craniofacial injuries, so these are multi-trauma patients. The important thing to remember, though, is that even when patients come in with a poor neurologic status, they can improve significantly, and also that a number of patients actually do have a pretty good neurologic status when they present. The keys are immobilization initially, well, recognition, of course, first, and then immobilization with sandbags, strap, and a cervical collar, and even considering a halo vest if you can't get somebody to the OR right away. But definitive treatment is an occipital-cervical fusion. We came up with a classification system, and it went into 3 stages. Basically, you had the stage 1, which was an incomplete or stable injury, and we often used a traction test to make sure that they could not disrupt the atlanto-occipital joint. If you had positive more than 2 millimeters of movement on that traction test, that was an occult unstable injury. But again, with multiple imaging modalities and advanced imaging, oftentimes the traction test has become obsolete. And so what we're finding is that patients are actually often present as a stable injury or an overt injury with more than 1.5 to 2 millimeters of occipital capsular disruption. Let's go through a case here. This just proves the point that oftentimes when these patients come in and are very disabled, they can have meaningful outcomes. This is a kid who came in with a motor vehicle accident, had an aortic dissection that almost cost him his life. He found to have traumatic subarachnoid hemorrhage at the craniocervical junction with an Asia motor score of 0. The parents pleaded with us to go ahead and do something, and so we were able to realign him and fixate him. And 6 months later, he was actually able to get up with a walker, showing that actually kids are resilient, first of all, and that these atlanto-occipital dislocations can be salvaged. This is another series from down at the Barrow. They had 28 survivors, again, showing that a lot of these patients can survive nowadays. And they simplified the grading to either normal findings based on CT with some subtle abnormalities on MRI, and those patients were put on an external orthosis, or with patients with abnormal CT findings and abnormal MR findings who underwent spinal fixation, so grade 1 and grade 2. This is a series from the former spine group at Vanderbilt, and what they did was they looked at over 5,000 spine consults and found that their incidence of AOD was 0.6% when they looked just specifically at the CT scan. Most of these were diagnosed early, but they had 9 patients who had no diagnosis of an atlanto-occipital dislocation. And they found that this missed AOD was the strongest predictor of mortality. And they found that a higher injury severity score and better Asia motor scores were also associated with missed atlanto-occipital dislocations. So now we have to talk about fixation of this, and we have good systems now with which we can fixate the cranium and fixate the craniocervical junction. These are biomechanically stronger than a lot of the systems we used to use, and you can put the screws just where you want them and have a good bone graft surface from the occiput to C1 or C2. Now, there's one point that I would like to make with this is I favor sort of more lateral fixation when I do these as opposed to translaminar fixation. This is based on a biomechanical study where we looked at occipital-cervical fixation and found that when we used C2 translaminar screws as the base of our fixation, there was less stiffness than when we used transarticular screws or C2 pedicle screws. Particularly, this is important, I think, in an occipital-cervical dislocation. Let's finish up with a case here. This just shows how resilient some of these patients are. It's a 48-year-old gentleman who was involved in a motorcycle accident in Reno. They did make the initial diagnosis, but he was placed in a halo and actually then transferred to Boise, then transferred to rehab in Pocatello, and then transferred to Salt Lake City. And each place he got a CT scan and the head was in a different position. And you can see there clearly he's got an occipital-cervical dislocation. You can see that here on the lateral images with the condylar C1 interval is greatly widened. And we went ahead and fixated this fella. Even though he had some significant injuries, he actually came back to me 10 years later to look at an L4-5 spondylolisthesis that he had developed. And so it again shows that these patients can make meaningful recovery. In summary, with the widespread use of multi-detector CTs, we were able to identify these craniocervical injuries using the craniocervical or the condylar cervical interval. AO dislocations can be extremely dangerous, and care should be taken to prevent secondary deterioration. Missed AOD is associated with mortality, obviously, or certainly worse outcomes. And even in young patients, you can have good neurologic outcomes, even with a presentation of a poor neurologic status. Thank you for your attention.
Thank you. Our applause is with you. Thank you, Andrew, for a superb big picture overview and emphasizing how important it is to make the call and make the right diagnostic moves and then act decisively and rapidly. Ashraf, in San Francisco, when was the last AOD that you've seen?
It was mid-September. Sorry.
Still an urban trauma center reality, right?
Yeah, it is. With the high energy trauma, this guy, I believe, was a fall from a pretty significant height, came in with an AOD and a C7T1 jump facet. So,
quick jump around North America. Welcome, Andrew, Edmonton. How's the snow?
Cold.
I'm
quite envious of what I see going on down there in California.
When was the last craniocervical dissociation you've seen?
It was quite some time ago now, probably a couple of years ago.
Okay, so not common. Zach, St. Louis, give us a quick update. When was the last craniocervical injury that you've seen?
Boy, probably the last time I was operating with Andrew. I haven't seen one for a while.
All right. Bazem in Heidelberg, what about you?
Hi, Jens. It's been actually a couple of years ago where we had an MVA with a complete dislocation craniocervically. So the patient didn't make it to the hospital, to our department at least. So this was the last case we've seen.
And Eric, thank you. I didn't have a chance to acknowledge your fantastic odontoid lecture. When was the last one that you've seen? Have you seen one in Tampa yet?
I saw a questionable one. It was sort of marginal based on MRI findings, very bright joints everywhere. But we placed them in traction, and the way I was taught traction testing was using a CT, and it's especially nice we have a portable CT scanner, and everything was robust, 10 pounds of traction. So it, we did not label it as such.
And I'll continue with the panel. Let's go to Morgantown, West Virginia. John, last craniocervical injury you've seen?
It was this past summer. You know, I found it interesting that, Andrew, I think even with multi-directional CT, they're still missed frequently. For some reason, the radiologist's eyes and people's eyes don't look at the occipital cervical region. So this issue of them being missed is significant.
And Rick, a question to you, Indianapolis. Is this still something that you see? Has the lockdown or the COVID crisis reduced serious cervical trauma? So what was the last craniocervical injury you've seen? And have you seen far less spine trauma during the lockdown?
So the last one I saw was a year ago, and it was missed, just as John said. Even despite having very good imaging studies, I think that there needs to be a very, very high index of suspicion, because these can be missed and could have devastating consequences.
How do we affect change then, Rick? Should we include neuroradiology more? Do we have to talk to our trauma surgeons more? Where can we as spine surgeons, who usually just get called as a last resort, then have a bigger influence to be proactive?
I think you're doing it, Jens. I mean, it is education, and having courses like this, publishing about this and showing the incidence of missed craniocervical injuries. But it's hard. You're right. It's tough.
So we'll switch to the lab in a second, and Rod is over there ready, and I'll join him because he'll tell us that we have to sacrifice the C2 route to do C1, C2 fusions and C1 fixation. And I say no. So yes, Rick, I'll represent you fiercely, as good as I can. I'm not as good as you by far, but I will try to do us justice. And I expect your commentary. Linda and Ashley, can you put up our ARS question? I want everybody to try to tone in on that. The question will be, in a frail elderly patient, to pick up on John Francis' theme of saying an elderly patient, do we actually need to do something, or can we safely ignore it? So if you're in favor of safely ignoring surgery for a frail elderly, please vote yes. Otherwise, hit the no button. We at this point in time are at over 130 live Zoom respondents. And I, as a host, am not allowed to vote because I wanted to say surgery has a role. Baz, you need to vote. And are we ready in the lab, Gary? Yes. So we'll switch to the lab in a second. As we're voting right now, Neil. Oh, Neil's in the lab. Never mind. Andrew, a question was made by one of our friends, actually it's Patrick McNulty from Las Vegas. Good morning, Patrick. Thanks for joining us. Is there a role for percutaneous fixation of C1, C2 motion joints and then removing these screws after the fracture has healed? Have you ever seen that? Is that something you'd find feasible?
You know, it's a great question from Dr. McNulty. I have not done them percutaneously, but I have done them open and taken them out at 12 months to see if we can get some rotation back in a younger patient. And I think we did achieve that. The problem is that's, you know, an anecdotal evidence as opposed to a case series. I'm not sure what's out there in the literature, but people have published on this to suggest that it could be a viable option. I don't know, Rick, if you've had any experience with that.
So, Andrew, I think intuitively it does make sense, but I tell you, we're all, you know, a function of our experience. And many, many years ago, when I trained in St. Gallen, Benny Jeanneret looked very specifically at patients that were treated with anterior odontoid screws and those treated with posterior C1, C2 fixation for odontoid fractures. And the thought is, I mean, the conventional wisdom is when we treat patients with anterior odontoid screws, we allow C1, C2 motion to continue, right? That's what we think. That's not what he found. He actually found that those with anterior odontoid screws still had profound limitation of C1, C2 motion. And so I think we need to prove that what we think may be true actually is true.
Very cool. So by the way, I'll ask Zach Ray to comment. It looks like, and I don't want to get political here, the red vote has clearly won, and we don't have any late mail-in ballots that I know of. So can you comment on the audience votes? 70 people voted, over 70 people. 61% said we can avoid doing surgery for type 2 displaced odontoid fractures in elderly. How does that affect your treatment decisions as you're seeing undoubtedly this weekend another sick elderly patient?
Yeah, I might disagree with that, even though it's going against the grain. I think I've tended to be more aggressive with these patients in terms of early treatment. If it's somebody reliable that really wants to avoid surgery, I'm fine giving them a trial on the collar. But I think these patients tend to do better with earlier surgery. So again, I would go probably against the grain with the audience there.
So this is.
Can I make one comment on the remobilization thing? We've had a few patients that have this complex array of upper cervical fractures involving C1 and C2, where it looked like if you were going to treat them surgically, it would be an occiput to C3 fusion kind of deal, which in a young patient, as you know, has a good bit of morbidity. When there's a lot of fracture component, we have done now a couple of occiput to C3 fixations and then removed the hardware at 6 months. And that clearly gives them motion. You know, when you remobilize their skull, they do get motion. Now, those are oddball patients with a lot of complex upper cervical fracture. Probably I'd be a little leery in more ligamentous injury, but there is an option for that.
Awesome. Rapid fire questions that are popping in, and we're switching to a lab in a second. Rod's on his way over already, and I'll join him in a second. So we have, first of all, we have Patrick McNulty again asking specifically for craniocervical injuries, but also for polytrauma. How safe is it to put a polytraumatized patient prone? Ashraf, maybe you at UCSF in your trauma facilities can address that. How safe is it to put a polytrauma prone?
I mean, we do it, you know, all the time. I think my biggest concern is always during the positioning. And so the big questions that typically come up is like what to do when the patient has an open abdomen and the fascia isn't closed. And I really defer to our general surgeons for that. Usually we're putting people in an abdominal binder for that. But then in terms of log rolling them, I'm usually doing it with the Jackson frame just to minimize motion, have them on the flat top, put the Mayfield and spin the bed for the ones I'm really concerned about.
Another question, and this is again, all really rapid fire here. I'm just selecting a couple, but we'll try to address some in the lab. Neuromonitoring for polytrauma. Boz, you have a polytrauma, unknown spinal cord injury status. Do you use neuromonitoring in that setting just to kind of cover your basis or not?
We do not use neuromonitoring. I know it's completely different compared to my colleagues in the US, and we already had that discussion a couple of times in our daily meetings at the SSF. We actually had great experience even in some patients with dislocated odontoid type 2 fractures. Even while we were repositioning those patients under X-ray guidance, we actually had great results. So no new neurological disturbances after surgery, but we do it always like slow motion.
And one more quick question as I'm heading over. Andrew, sorry, the questions keep coming, but it's fantastic to see such a wonderful audience. Andrew, timing of polytrauma fixation, craniocervical dislocation, do you try to just push hard to get this patient done? Is there any way that you can kind of immobilize them safely until they're actually cleared by your trauma colleagues?
So what I'll do is I'll put sandbags, tell everybody that there's an AOD, and actually tape their head to the sandbags. Although, you know, obviously that can still move. It at least alerts everybody that they should not be moved. Of course, they're staying in a collar during this whole time. Now, you know, I've had to delay on a couple of these. I had a vena cava injury and then that aortic dissection that we showed, and we didn't get to those till 5 to 7 days later. And there was no demonstrable neurologic worsening in either of them. So I think if you alert people and make everyone understand there's an AOD, hopefully you can avoid the downside of this.
Andrew, I'm going to turn off here because we're going to switch to the lab, but you're the last one. Patrick again asks, if a patient is turned prone and you're getting significant cardiopulmonary problems from the anesthesiologist, how do you troubleshoot that?
Another great question. I think, you know, I use a lot of neuromonitoring when I do these. So, you know, the first thing I would do is I'd make sure I check neuromonitoring and make sure there wasn't a decline and that it's not, you know, brainstem compression that is causing the cardiopulmonary instability. I think you'd have to turn the patient back supine. Obviously, this is something you do this with multiple people in the room. This is not sending the junior resident in to position the patient. This is the attending going ahead and making sure that patient is positioned prone. Take control of the head, turn it back over.
Got it. Rick, I'm sorry, out of time. We can't show you a great hangman's fracture right now. I hope we can go for that later, but let's get your commentary and everybody's commentary as we're switching to the lab. Gary, are you ready? Dr. Skuin is going to show us how he addresses C1, C2 fusions posteriorly, and I'm going to join him in a second. I'm going to try to preserve the C2 root on my side. And thank you all for a great discussion.